Okay, guys, so welcome back. In this part, we'll talk about the pathophysiology of obesity. So the first thing we kind of need to unpack that there are two different types of adipose tissue, right? So when we're talking about obesity, we're really referring to an overaccumulation, right, of body fat, right? But there's two types of body fat. So we've got white adipose tissue or white fat, which is what we think of when we're thinking of of obesity, right? It's we use for lipid storage, and it goes under pathological expansion during obesity. We also see it. Some of the properties of it change. The innervation to the fat changes. We see actually a loss of sympathetic innervation to it. So there are a lot of changes that happen to the white adipose tissue in obesity. But when we're really talking about an overaccumulation of adipose tissue, we're talking about white adipose tissue. And then there's brown fat or brown adipose tissue. This is thermogenic, has a large amount of mitochondria, dissipates chemical energy stored as heat. So it helps contribute to our energy expenditure. We kind of burn energy through here to produce heat. There's large amounts of it in infants and begins to decrease gradually with age. And we think it may play a role in body weight regulation. We actually find there may be some changes even to the distribution of white to brown fat in obesity. But brown fat, again, a little bit different story. Again, the type kind of matters. In fact, it's important to note that brown fat does play a role beyond just energy balance. It's used to kind of keep our certain regions kind of warm. So we find them in stereotype locations under the supraclavicular fossa, the axilla, the mediastinum, the paraphrenic and adrenal areas. It's really important, actually, that kind of like areas in the neck. It helps keep the blood going to your brain at a set temperature. So it's actually pretty important for that role. So that's a brown adipose tissue. Again, there's a difference in type, right? So again, white is what we're associating with excess weight or high adiposity, weight gain, and then we've got brown adipose tissue, right, which contributes to energy expenditure, produces heat, high amount of mitochondria, and again, this changes with age, but we also see changes to both of these in obesity. One being a higher amount of adipose tissue, and in fact, the adipose tissue in and of itself gets dysfunctional. So we start seeing changes even in the white adipose tissue. Now, in terms of adipose tissue, not only does the type matter, right? The location matters. So when we're thinking of obesity and a lot of the pathological changes that occur with it, we're primarily talking about visceral or intra-abdominal adipose tissue, and specifically white adipose tissue. This is the adipose tissue that surrounds our abdominal organs, which you might remember from anatomy, right? If you saw that, white tissue, right, or white fat tissue. Now, when it's located and accumulated there, we see higher expression of inflammatory cytokines like tumor necrosis factor alpha, interleukin 6, right, which we'll kind of get into in a bit, but we typically see these elevated in most inflammatory conditions. We see a higher sympathetic activity, right, which can contribute to a lot of other problems. And this again is what's strongly linked to all those cardiometabolic conditions like heart disease and diabetes and all those other not so great conditions. Now, subcutaneous adipose tissue, stuff that's just underneath your skin, that's not necessarily hazardous to your health. And we think actually where you may distribute fat may kind of matter. But again, subcutaneous versus visceral, a little bit different, right? So when we're thinking of obesity, the type matters, brown versus white adipose tissue, and where it's located, right? Subcutaneous, not as a concern, especially if it's located more in the gluteal-femoral region. We're really more concerned about visceral, right, and intra-abdominal fat. And then we'll get into as well perivascular adipose tissue, the fat that surrounds our blood vessels. And we'll get into that because that's particularly relevant for heart disease, hypertension, and a lot of other cardiovascular concerns. Now, one thing I want to stress, adipose tissue is not a passive tissue. It doesn't just do energy storage. In fact, no cell in your body, right, no tissue in your body, it has, it's just a passive structure. Your muscles aren't either. But adipose tissue is very much so alive. It's viewed to be, it's very, very active. It has autocrine, so it has changes that can occur within the cell, so it can affect or it can affect itself in a certain sense. Like I mentioned, in obesity, we actually see changes within the adipose tissue. It's a paracrine structure, so it can affect neighboring structures, and we see this often with the muscle that surrounded by fat, as well as the vasculature. And it has endocrine function. So the hormones and the cytokines that are released from adipose tissue, called adipokines, if they get into your bloodstream, they can have effects profusely throughout the body, the brain, the kidneys, other areas, right? So adipose tissue can affect a lot of different things, right? It's not just passive energy storage. We actually find it produces its own ANG2 and reactive oxygen species, right? So again, it's not just this passive receptacle, right? It has a lot of other roles. Now, it's important to note, right, that adipokines, which are these things that are released by adipose tissues, these cytokines. Now, there are some beneficial ones, right? Probably the most important one would be adiponectin, which we think is a healthy or pro-health cytokine. It also secretes things that are not so healthy, and that's like the TNF alpha, the IL-6. And we'll get into later on, we're finding that quite often in obesity, we see a lower production of adiponectin, right? So adiponectin, which again is healthy, especially for the vasculature, that decreases, whereas those pro-inflammatory adipokines, TNF alpha, IL-6, increases. So again, think of obesity a little bit broadly, even at the cellular level, right? It's, the tissue properties, even of itself, sort of change, right? Because you need some fat, because it does release these pro-health factors called adiponectin. But when we accumulate too much adipose tissue, right? When we, especially white adipose tissue, and they start having, pathological changes, their function changes as well, right? We see lower adiponectin, higher inflammatory cytokines released from the adipose tissue, which causes all of these problems here. Okay? So now specifically perivascular adipose tissue. So it's important to remember, going back to basic physiology, vascular homeostasis is generally maintained between the balance of the opposing actions of endothelium derived relaxing factors and contracting factors. Two of the biggest ones, nitric oxide, which is a relaxing factor, and then we have endothelin 1, which is a contracting or constricting factor, right? So ET1, vasoconstrictor, nitric oxide is a vasodilator and counters the effect of ET1. Now, under normal conditions, these are balanced out, right? And actually things tend to favor nitric oxide. And again, in obesity, right, we see changes. So again, in healthy conditions, we have healthy adipocytes. They secrete adiponectin, which actually increases the nitric oxide bioavailability. So again, in a normal situation, your adipose tissue is actually pretty important for maintaining normal bodily functions, producing nitric oxide or increasing the bioavailability of nitric oxide. Now, when we are in a state of obesity, when the adipose tissues, right, are hypertrophied, right, when they've got pathological changes to them, they're disturbed or impaired, right, we see changes in this balance. We see a lower level of adiponectin. We see a higher production of pro-inflammatory cytokines like TNF alpha, IL-6. TNF alpha reduces nitric oxide bioavailability and thus increases or favors the balance of endothelin 1, which is constricting and you know, we're going to have higher vascular resistance because of that. When we also see an increase in reactive oxygen species in Ang2 in obesity, which will also impact vascular homeostasis, right? So leading to all kinds of other pathological changes in the vasculature. So again, in obesity, we see a higher, the higher amount of adipose tissue. The adipose tissue is abnormal, it's pathological, and its function changes, right? From releasing these kind of healthy adipokines like adiponectin to releasing less adiponectin and more pro-inflammatory cytokines, which will reduce nitric oxide bioavailability, which will allow endothelin-1 basically to operate unopposed, right? And we end up leading to a balance that favors vasoconstriction, favors platelet aggregation, favors endothelial dysfunction, right? Because remember, our nitric oxide is really important for maintaining the health of our endothelium. So again, under normal situations, this is balanced. Obesity, things change, and then we start seeing problems. And again, this is just a graph here kind of describing this relationship a bit more broadly. It also describes the role of insulin. So insulin, when we eat, right, is secreted. That helps us uptake glucose into our cells. However, when we have too much adipose tissue, we end up affecting this regulatory signal. So insulin is a vasodilator within your the blood vessels in your muscle, which are the largest sink, and it ends up again affecting that vasodilator, vasoconstrictor balance. So you end up having vasoconstriction. You have lower uptake of glucose into the muscle. So that's one of the ways that obesity impacts metabolic regulation by affecting the local vascular supply in the muscle and in its response to insulin, which is normally a vasodilator. So coronary peripheral adipose tissue, or PVAT. So again, in normal situations, coronary PVAT, right, especially the epicardial PVAT, has very little effect on the coronary arteries. Again, it's pretty similar to even the peripheral arteries. It releases some adiponectin. Like you need some peripheral adipose tissue or perivascular adipose tissue, even in the heart. But like obesity, when we have the expansion of adipose tissue isn't just one area; it's kind of diffusely through the body. So the perivascular adipose tissue in the coronary circulation changes too. And same exact certain things we see alterations in the vasodilator, vasoconstrictor balance. We see elevations or expressed activity of calcium channels, which increases vascular tone. We see alterations in the potassium channels, which affect relaxation. So we see, again, something that favors vasoconstriction and higher resistance, which makes the heart have to work harder to perfuse itself. We also see a higher prevalence of atherosclerotic plaques form over areas when there's more epicardial fat. In fact, I remember during residency, we have to watch a bypass surgery on an obese patient. I'll show you kind of what it looks like in a second. That their fat was encased with this perivascular adipose tissue, and actually made it very difficult surgery. And again, it's kind of what we're showing here. Again, these changes in the cells, in the circulatory, right, in the vessel structure here, just showing kind of what we see in someone in a lean heart. So again, there's always going to be a little bit of perivascular adipose tissue, but as we, as you become more obese and have metabolic syndrome as well, in concert with that, you see an expansion of that perivascular adipose tissue, which affects the quality of the artery, right, with something favoring constriction. We also see hypertrophy of the artery as well, again, due to changes, inflammatory changes in those calcium channels and potassium channels as well. So in addition to just changes on the vasculature, obesity has implications on the muscle too. So obesity may induce a process called myosetosis, which is the presence of intramuscular and intramuscular adipose tissue. So it causes pathological changes to the muscle structure, like, as well as insulin signaling, as we talked about as well, like insulin being our vasodilator, and our muscles being basically the sink for postprandial glucose uptake. That process is completely, not maybe completely impaired, but is impaired in obesity, through those inflammatory cytokines, most notably TNF alpha. Now, with these changes in the muscles, we think there's multiple mechanisms. We think that maybe just the accumulation of adipose tissue and those paracrine functions affecting the tissue right next to it or neighboring it. There may also be just inflammatory changes, diffusely, macrophage and T cell accumulation in the muscle causing changes. Again, overall, scope of these changes is that we see an alteration in the muscle composition, the architecture, the structure of the muscle, as well as even its contractile properties, right? So again, like we see these changes in the ability for the muscles to produce force, in patients with obesity potentially as well, which may exacerbate the normal aging process. So especially in people who are elderly, this may be a particular concern, because as we age, our muscle mass tends to decrease. And it's just an example again, with this increasing fat accumulation, we have all these pathological changes in the muscle. It may also affect the bone too. We're finding that the muscle, the bone, and the adipose tissue have a crosstalk relation. They all kind of talk to each other as well. So this kind of architectural changes within the muscle here, again with increasing fat accumulation. Now, there are also hormonal changes that occur with obesity that affect the muscle. So with increased obesity, you see a reduction in anabolic hormones like growth hormone, IGF-1 or insulin growth-like factor, as well as testosterone, right? It's actually a big problem with gynecomastia in certain patients who become obese. They also see, again, the increase in all those pro-inflammatory cytokines. TNF alpha is always a culprit, right? We also see increased secretion of an expression of myostatin. Myostatin, again, is a hormone that, if it's increased, it reduces the hypertrophic responses to exercise. It's actually something, if you guys have ever looked at that, I think there's a meme out there of these like super muscular cows. Those are cows that have their myostatin blocked, right? So they get really, really muscular. In obesity, we see actually an increase in myostatin. So it's maybe even harder for patients with obesity to gain muscle mass, right? And again, we talked about the role of insulin as a, in terms of uptaking glucose postprandial, right? It's the vasodilator. That vasodilator balance is changed. That ET1 balance is running, ET1 is basically running unopposed. Insulin is also an anabolic factor, right? So when we have decreased insulin sensitivity, which happens, right, with obesity because of those inflammatory changes, as well as, in concert with metabolic disease and with diabetes, skipped over this. Didn't want to skip over that. You end up seeing reductions in insulin's role in muscle protein synthesis. So again, the changes that occur with obesity are a lot broader than just somebody just accumulating more fat. This accumulation of fat has other effects throughout the body, and again, which may make it harder even for patients to get the benefits of exercise, right? We have all these adipokines, these hormonal changes potentially going on in these patients. So just be aware of these things, right? And there may even be changes in terms of exercise responses. There's a nice little graph here describing some of those changes, right? At a given work rate, they're going to be consuming more oxygen. So black dots here are obese, normal weight in the open dots. So at a given work rate in watts, they're consuming more oxygen because it's just a little bit harder for them to work. We typically see cardiac outputs higher because the heart rates are higher at rest because they have to perfuse themselves. So VO2 tends to go up. It's just harder for them to move around at a given work rate. We see ventilation. They're breathing at a much faster rate compared to a normal individual, which may lead to, again, while they have issues with dyspnea at a given work rate as well, and may not even be able to get to a certain work rate. As you can see here, they end off at about producing 110. This person normal weight was able to get to, the normal weight population in the sample was able to get to about 140 watts of work rate. So we'll get more into some of the ventilatory responses and changes in patients with obesity later on. But again, there are profound physiological effects or physiological changes that occur in patients with obesity. You kind of need to be aware of these things. So we'll end here. I hope this was a nice synopsis of the physiology. I didn't dive too deep into it. But it's important to understand these things. Now, the next thing, we'll talk about some paradoxical relationship with obesity, which you may or may not be aware of.